My name's Rosemary Brander, and I'm the Director of Interprofessional Education and Practice at Queen's University and Senior Researcher and Program Evaluator at the Center for Studies in Aging and Health at Providence Care. You got through that one. And I'm very excited to be here today to take part in this session on collaborative practice. The objectives of this afternoon's session are to share our collaborative practice knowledge and to respond to 4 questions, which we'll just drop down on the screen. I'll just read them out. What do you like about the principles of collaborative practice? Tell us of a positive experience you have had with collaborative practice. What do you see as the challenges regarding collaborative practice? And what collaborative practice strategies, models are you successfully implementing? So we put these up right away because we want you to start percolating and thinking about them as we proceed through our workshop this afternoon. I also want to mention that part of our group sharing in the workshop will help us create the conference white paper, which was mentioned earlier, and that will be on the website post-conference. So we're hoping that we'll have really rich discussion. We want people to bring all of their ideas to this shared document that we're building today. So the timing for the next hour and a half will be that we'll start with a presentation by Cynthia Phillips, and then we'll get together in our tables for a group knowledge exchange and have discussion around our tables about these 4 questions. And just to give you a heads up, each table will need to identify a recorder and or a reporter, someone who's willing to speak to key points at the end of that session. So that session will go about 35 minutes. And then we'll have a large group knowledge transfer where we'll ask each table to present 2 or 3 key points from their discussions. And we'll do the questions one by one, take them around, and as we exhaust information, we'll try to move on to the next question so we don't have a lot of repetition in our discussions. And then we'll have a quick wrap up at the end. So I'm going to try to work hard to keep us on time so we can get away for coffee and good time in our final sessions this afternoon. So at this time, I'd like to introduce Cynthia Phillips. Cynthia has been a registered respiratory therapist at the Kingston General Hospital since 1984, including roles as clinical educator and clinical manager for respiratory therapy. She is currently the manager of Interprofessional Collaborative Practice and Education and has led the Model of Care initiative at KGH since 2009. In her current role, Cynthia has managed the role out of KGH's Interprofessional Collaborative Practice Model of Care and Education throughout the hospital and plays an ongoing role in evaluating and sustaining changes in practice. Cynthia graduated with a Bachelor of Arts in Health Studies from Queen's University in 2003 and earned a Master of Education from Queen's in 2007. Please join me in welcoming Cynthia.
Thank you, Rosemary. The food has been great, hasn't it? There's been lots of it. And so the outline for the presentation is listed here. I hope you can see because you may want to come over here. Just tell me to move if you can't. So we'll get going because Rosemary's timing me. There's a little bit of information here about our hospital for those of you who don't know. And this morning when Leslie was speaking, I was thinking, well, that's what I wanted to tell everybody about the strategy. Our strategy was launched in June of 2010 and founded on input from almost 2,000 individuals about what they believed was important for Kingston General Hospital. Half being our staff as the internal stakeholders, and the remainder being our regional partners, our patients, families, and patient groups. So we have 4 strategic directions. The first is to transform the patient experience through a relentless focus on quality, safety, and service. And the second is to bring to life new models of interprofessional care and education. So we got to work And the interprofessional collaborative practice model, our mandate was to design, implement, and evaluate a viable model of care delivery that is patient and family centered, high quality, safe, and cost effective. So really, it's a means of transforming the care delivery for our patients and families. Why are we doing this? It began in 2009, and again, Leslie spoke to this morning as part of a fiscal recovery. We wanted to ensure the quality of work life and the work environment was not compromised in any way, and ideally were improved as the financial recovery was managed. So that's how it began. And we all know that today's society is characterized by an aging population that is faced with increasingly complex comorbidities. And this has led to a growing awareness that innovative models of care delivery are needed. Patient care can be organized differently, professionals can work differently, and more to their full scope of practice within the context of their specialty. We all know status quo is not an option. So a little bit about our design process. We brought together 54 healthcare providers and support staff. We had as many disciplines and services represented at the table, and I think some of you are actually in this room, which is nice. The team spent the first session, 4 sessions. The first one that we looked at issues and challenges affecting care delivery. And I was there, and it wasn't pretty. We heard chaotic, uncoordinated, right hand doesn't know what the left hand is doing. It was a tough session. We got through to the 4th session and came up with how we thought care should be delivered at KGH. And the team called it the interprofessional collaborative practice model. The design team validated what we already knew, that we were underutilizing the workforce and there was a significant opportunity to make changes. These were the challenges that we heard to interprofessional collaboration, and one of the most significant and continues to be the most significant is communication. So here is our model of care that was designed by the design team. So our patients and families at the center receiving high quality care. And around the patients and families are 4 levers for change: our people, our processes, our information, and our technology. And the message here is that every lever is important to ensure care is patient and family centered, high quality, safe, and efficient. If one of those levers slows down or breaks down, it not only affects patient care, it also affects the other levers. And this is the collaboration, the working together piece. So what we expected was to enhance patient and health outcomes, to minimize service duplication, to reduce service duplication and minimize unnecessary interventions. One of our goals was having the right care by the right person at the right time. And I will speak to this later, but that is one of the lessons learned, is that we really have to be careful how we message things, because now recently I'm hearing, oh, I don't have to do that, that's not my job, ICPM says so. I'm not the right person for that job. So it's really to be aware of the messaging. We wanted all disciplines working to their optimal scope of practice, to improve recruitment and retention of healthcare providers, excuse me, and to optimize staff participation in clinical decisions. So we got to work, the design was set, we knew what we were doing, so we looked at the different levers, we set up teams, and we went to work. We had an HR team, a human resources team, and we sat with people and we discussed their roles with the goal of having the right person doing the right job at the right time. And we talked to them about what they were doing that only they could do, and then worked towards ensuring that we had the right people. A process design team, we took the top 5 processes we heard about the most, the ones that just didn't work very well. And they were discharge management, documentation, shift report, or handing over information to the next care provider, and that's often where information gets lost. And the last two are obtaining meds and supplies 24/7. We're a big hospital. You can get whatever you want at 2 in the afternoon, but at 2 in the morning, it's not quite the same. There's lots of delays in care. When we move to the outpatient settings, they don't care what happens at 2 in the morning. They're not there. The processes started changing. So depending where we were going, within the outpatient areas, they cared about delays with transporting patients from one area of the hospital to the other and getting them there on time. So there was different priorities. We had a technology team, and their job was to make sure people had the equipment they needed to do their jobs, that the equipment worked, they knew where to find it. They thought they had the easy team. It was not easy, but they did get through it. We had a finance or a staffing team, and what that gave us was the opportunity to sit with leaders and look at the staffing model and see where we could make changes. So depending on the patient population we were serving, there was lots of changes. One unit, one of the general surgery units, thought they needed more environmental services. And so we worked towards that. Another unit wanted physiotherapy on the weekends. Everybody had their priorities depending on the patient population. A documentation team, and it was one of the original processes, but we separated it. It was a very large change, and it needed its own team to work through. An education team. We implemented, so what we did was we implemented on 2 units at a time, and we tended to take 2 units who didn't normally work together, a medicine and a surgery, just a real mix, and we brought everybody together for interprofessional education. Everybody got the same messages. To date, we've educated over 2,200 staff across the organization, and bringing people together. It doesn't matter what the role is, everybody comes together to learn. And a communication team, of course, everybody wants to know what's going on, especially if they will be affected. So it was to keep people informed in whatever manner suited them. And we were all set to go. We chose an implementation date in our 2 units, and we're all set to go. And we realized, what were we missing? We were missing our patients and families. So we had gone through the whole design and the pre-planning without any thought of including patients and families. And that's really how it started at KGH. And again, Leslie said this morning, the shift from doing to and for our patients to doing with our patients and families. So we set up a patient and family advisory council, and we have 12 patient experience advisors. They're former patients or family members, and they meet monthly with 4 KGH staff and 1 physician. And I'm so fortunate to be one of those 4 staff. It's a very rewarding experience. And any issues that may affect patient care are brought to the council for advice and input. And the agendas are getting longer and longer because there's more and more ideas that are coming forth. So that's really how it began. Here's an early picture of our council. So our first meeting was January, and this was in May, and I was explaining about the model of care and all the things that we could potentially do, and Leslie actually came to that meeting and was listening, and I thought, oh no, they're going to cut us off, right? They're not going to let us do all these things. But no, people were so energized and wanting to make the changes. So we set to work, as I said, 2 units at a time. We went through 18 inpatient units. So our focus initially was on adult inpatient med surg. Then we went to specialty care units, then to the outpatient and ambulatory areas. And we branded ourselves, and this is our logo, ICPM, Circles of Care. And what this really is, I know you probably can't see, and I'm sorry. So patient at the center, and around the patients are 24/7 care providers, our consultant care providers, and our support team. And that, again, is a lesson learned for me. Be careful how you brand yourself, because it's really difficult to change. Two things: I would not put the patient at the center anymore. The patient is part of the team, so on one of those, on the 24/7. And the word interprofessional excludes a lot. People feel excluded. So we try to ensure that people realize everybody has a unique role and is a professional in their own way. But that's a really tough sell. And also we've heard from the patients and families, where do we fit into that? So it's just a word of caution. Here's some of the changes we've made. Our patient and family-centered care changes. Really, you were hopefully at the session this morning, but it means involving patients in all their care planning and decision-making, having them there at every step of the way. The first change we made was November 9th, 2009. We lifted restrictions on visiting. We have no visiting hours. Families are welcome. They're part of the team. It was based on scientific evidence. People were afraid of infections and all kinds of things, and there is no evidence for that. Our visiting was 2 p.m. to 8 p.m., and you could literally see people coming down the hall at 2 p.m., and of course everybody wanted to see the doctor because they had questions. We know the docs aren't on the units at 2 p.m. They're in clinics, they're in OR, they're not on the units waiting for visiting hours to start so they can answer questions. At 8 p.m., nobody wanted to leave. We actually had to have security to try to get people out because they knew we weren't going to let them back in. We probably weren't. So anyway, that's all gone. Families are welcome. They want to be there when the physio is happening because they're the ones that will be helping with the exercises. They want to know what the blue pill and the white pill and when to give them and how to, what to give them with. They want to be part of it. It was a really big change. People were really nervous, and we have had very few issues. It's been a really positive change. Other little things, we put whiteboards at the bedside. It says today's date, your nurse's name, your patient care assistant's name, and a section for comments. Whether that means I could write a comment, please bring the running shoes, we need them for physio tomorrow. Last week I was on the unit and I saw, Dad, I dropped by to visit, you were sleeping, I'll come back after work. So more and more people are using those whiteboards. Frequent patient rounding. What we do is we try to go around frequently and we look for 4 things. Does a patient need to be repositioned? Do they need the nurse for pain control? Do they need assistance to the washroom? And ensure everything's within proximity, the table, the Kleenex, the water. And what we find is, of course, it's improving patient safety, but it also decreases call bell use, which makes for a nicer environment for the patients, the families, and the staff. So lots of little things that we implemented. Here's a more recent picture of some of our patient experience advisors. And I see some of them, I think, in here, yes. This one was about 1.5 years ago, and we now have 54 patient experience advisors at Kingston General Hospital. They came up with this big definition for what patient and family-centered care is at KGH, and I know I should know it, but I never remember it. So they came up with these 7 words: respect me, hear me, work with me. Our patient advisors are on all kinds of working groups. They have participated in over 100 job interviews. They sit on the interview panels, everything from director level to healthcare providers. They see and hear things totally different than we do. They're looking for different things. They participate in monthly orientation. Andale, our MC, is there just about every month, welcoming new staff and telling them about patient and family-centered care at KGH. And the patient experience advisors are on all kinds of committees, including the quality committee of the board now. So they're really being embedded across the organization. Our people changes, I tell everybody, blame this on ICPM. These are our new ID badges. We heard loud and clear. We failed to introduce ourselves. The patients want to know, am I the pharmacist? Am I the physician? I mean, we all look the same most often. So they're easy to read, the same on both sides, and they're to be worn so that it's visible for the patients and families. Little thing, big difference. Role reviews I spoke to. We implemented 2 new policies. One was an interprofessional consultation policy where any member of the team may consult any other member of the team if the patient's care would benefit. So the consultant comes, assesses the patient, and is then responsible to get their own orders for care. So as a respiratory therapist, I know when, we need a speech language pathologist or a physiotherapist. Now I can put that consult in. The other one is a regulated health professional suggest order where any member of a regulatory college in Ontario can write a suggestion to modify the plan of care on a pre-printed order sheet. It's an order when it's signed by the prescriber, but it's within each discipline's scope of practice. Before ICPM, we had a nurse suggest order and they were allowed to suggest 6 things. That was it, nothing else. We took away all the limitations and let every discipline work within their scope of practice. So those things go a long way to involving, decision making and care. Technology and information changes. Not only do we change how people document, the whole methodology, we also moved where they were documenting. So the nurses before ICPM documented on a flow sheet that was kept in the room. The physicians documented in one place and then everybody else somewhere else. And then we kept the medication record down the hall in the med room. So it was really hard to follow the flow. Everyone now documents in the progress notes in chronological order. What we did was we put these wall desks outside every patient room. Unfortunately, we are not at electronic documentation yet. Someday we will get there, but we're not there yet. And we took all the patient information and moved it to the wall desk outside the patient rooms. The desk opens, it's a writing surface, and then it closes and contains all the information. So in essence, what we've done is we've taken all the action away from the care team station and moved it out closer to our patients and families. And that's a great thing. The other thing we're trying to do is improve or optimize the use of technology. The hospital came out recently with a social media policy. Before that, it was banned. Now it's okay, we're following the guidelines. Something else we have are these Vocera devices. I'm not sure if you know about these, but most people wear them, and you wear them close to your mouth. And it's an answering machine, it's a locator, it's a pager, it does everything. And so I can't really turn it on because there is not a receiver in this room, but even if I'm in an isolation room and I'm gowned, I can hit the button and call Rosemary and ask her to bring me the 4x4s I left out in the hall. Or if I can call her and, can you come and give me a hand for a minute? Or it's just really efficient use of technology. Process changes. The biggest one is discharge management beginning on admission. We have daily rounds where we address barriers or challenges to discharge and what we're going to do about them. We set up a consult phone line. The extension's 2222. Press 1 for physio, 2 for social work, 3 for community care, case man. It goes through the whole list. Easy to leave a consult. We have pharmacy technicians. This is one of my favorite changes. The pharmacy technicians used to be in the dispensary, which is in the basement, and that's where they worked. Now they are assigned, every unit has a pharmacy technician they can call, and the pharmacy technicians are involved in medication reconciliation now. So it's been a big change for them. Is ICPM transforming the patient experience? Well, we had to evaluate, and we've spent a lot of time working on an evaluation. It's a pre and post mixed method, so we have qualitative and quantitative, and we target patients, families, staff, and physicians. We're currently evaluating 6 inpatient units and 8 ambulatory areas. I have just a couple of slides of 4 adult inpatient units that I just want to show you some of our results. So with our patient surveys, we use a Queen's. It's a tool called, it's from the Office of Interprofessional Education and Practice, and it's a 20-question survey. with an open-ended question. And what we do is, as soon as there's a discharge order written, a member of the evaluation team or a volunteer approaches the patient to see if they would complete the 20-question survey, and then there's a box on the unit. So we're trying to get them between the time they find out they're going home and the time they actually leave, which is tough. But we did hear early on from our patients that they didn't want to fill out surveys early in their stay because they were afraid it would affect the care. And so we tried to delay it as much as possible. And our provider service is, again, a Queen's tool called the Collaborative Practice Assessment Tool. It's 56 questions plus 3 open-ended. And then we added some job satisfaction and empowerment questions as well. And got this out to all the providers, both hard copy and electronic. We also had a team who did chart reviews, and they do them for 4 weeks on every patient admitted to an ICPM unit. And they identify delays in care, they look for quality issues, delays in discharge, and really helping us evaluate the effectiveness of ICPM. So here is our patient survey. And these are 4 units: general surgery, orthopedic surgery, medicine, neurology, and medicine. And we surveyed our patients before we implemented the ICPM, and then at 3, 10, 16, and now 30 months after we implemented the changes. So this question says, it appears to me that my healthcare team works well together. And this is the percent of patients who strongly or mostly agree. And so this reflects teamwork and collaboration from a patient perspective. I will acknowledge the sample sizes are different, but the trend is stable. So it's not always that you have to see really positive trends. It's, if things are good, make sure you keep them that way as well. This is another patient question. It seems to me that my care is well coordinated by the team. And again, the percent of patients who strongly or mostly agree. And again, same trends, and there are variations between units, but high scores. This is one of the provider, and actually what I've done, this tool goes through the 8 domains of collaborative practice, and I have collapsed them to give you an idea of what the providers are feeling about how we work together as a team. So these are the 8 different domains, and this is the percent of staff and physicians who strongly, mostly, or somewhat agree. So again, you can see where there are definitely changes. So limitations, of course, our patient survey distribution process, it's really difficult to get there between the time the discharge order is written. I mean, what the patient by then wants is, get me out of here, is what they want. The provider response rates, we're a busy hospital. We're also affiliated with Queen's and research studies. There's surveys all the time. And this one's quite long, so our 64 questions. So our response rates are a bit low. When I was going through my results, what really struck me was that those 4 units have all had leadership changes. They have all, each one, been moved off their home unit. We moved them, decant them to another unit, pulled out the carpet, renovated. That was a very stressful time when they weren't home. They were somewhere else, and then we brought them back. And that all happened in this evaluation. And the staffing changes. We've had so many staffing changes. I'm really not sure that the staff who filled out the surveys before ICPM are the same ones filling it out at 30 months after ICPM. So there's a number of issues. Some of the challenges we've encountered, for me, the biggest has been engagement of staff and particularly physicians. That has been such a challenge. Buy-in from different units and different positions. So even within a unit, you get the different buy-in. Everybody thought we needed change. Everybody agreed as long as it didn't affect them. and that wasn't going to fly. Other people were saying, I don't know why you're doing this, we're already doing all this, until the day you go to implement and they go, whoa, we're changing too many things at once. So you're getting every different perspective. The culture of fear and distress in the organization. Everybody is afraid. And there's so many initiatives happening at the same time. There's just all kinds of things going on. I think key lesson would be to engage your stakeholders, and I'm including patients and families right at the beginning. It would have been a lot probably better, easier, and different. If we were to do it over again, I did mention the branding and the perception of excluding people and the idea of the interprofessional. Be prepared to revisit changes you've made. Some of our process changes didn't work, and we had to go back and make more changes, so the patient's piece. I would now separate the documentation changes from the ICPM, because ICPM became documentation, and everything else kind of got forgotten sometimes. Or anything bad that was happening, it was like, that's ICPM probably that did that. So, gotta be tough. So to me, collaborative practice really is about knowing each other's roles and scopes of practice, including overlaps. Communication, whether it's formal, informal, or virtual. People say to me, well, if you really want us to know, why don't you just put it on Facebook and then everybody will know. So, it's how different people want to learn. Documentation, really to facilitate continuity of care. And these elements actually meet the Canadian Patient Safety Institute safety competency related to working in teams for patient safety. One of the key lessons that I have learned is patient experience is transformed by 3 pillars: collaborative practice, patient and family-centered care, and interprofessional education, and it really does take all 3. I was working on some of the newer evaluation results, and areas that have never really been involved that are now participating. When I look at the changes in the OR and in the imaging department, and I truly believe that bringing people together for interprofessional education has had a lot to do with that. And hearing from people that you never work with, they are encountering the same issues and challenges, and it really brings a new perspective. So what we want to do is continue to learn from our results and ensure sustainability, and that's tough. Lots of audits, lots of monitoring, ensuring we hold people accountable, that it's an expectation. And for me, what I would like to do is work towards a 7-day model of care. Everyone wants to be valued for their expertise, but not necessarily 7 days a week. And as far as our patients are concerned, we need seamless care. It doesn't matter if I have a stroke on a Tuesday or a stroke on a Saturday, I should get the same level of care. So, and of course, we want to celebrate our wins. So I hope that gave you some idea of the ICPM at KGH. I have some cards here, and I'd be happy to answer any questions or meet in the break. I think Rosemary's going to try to keep us on time, so I don't think we have a lot of time for questions right now. Thank you.
Thank you so much, Cynthia. It's the second time for me listening to Cynthia present on this information today, and I'm glad I've had the opportunity, because I keep picking up different pieces of information that she's shared. And what struck me this afternoon is the openness that she is displaying in sharing not only the successes that they've had in 4 years, but in some of the difficulties that they've had, and that's okay. It's a process, and they might not have picked the perfect brand or the perfect way to do things each time, but I think in hearing the lessons that they've learned through the processes, that will help us all move forward. So thanks, Cynthia, for that. So we'll now move to the right title of this, the Group Knowledge Exchange at our small tables. We have about 30 minutes to do this and to respond to the 4 questions that are on the screen. And you'll see at each of your tables a workbook like this. And it has the questions listed in it. And if the scribe would scribe the information and someone can decide to report at the end from the table, that would be good. We're using this information to share in our wide knowledge exchange. So we're trying to encourage everyone to have a very open discussion, rich discussion. So please bring all your ideas forward, whether they're controversial or not. We appreciate hearing them. And if there's anybody who's odd man out on a table, please, if you would join another table. We're trying to get groups of 6 or 8 together. And Amanda Chudak, where is Amanda now? Here she is. She's going to be helping us with our materials and recording. She's our rapporteur today. That's a new word that I learned today. And there's pencils and highlighters available. Yes, and this information is going to build the white paper that I mentioned a little bit earlier as well. So Amanda and Cynthia and myself will be circulating. If you have any questions, please direct them to us. And I'll give you a warning just as we're getting to the end. After this, we're going to come together and we'll have 20 minutes to share the discussion, and then we'll have a brief wrap up and set everybody away. Thanks. So is there a table group that would like to respond to the first question? What do you like about the principles of collaborative practice?
What our group spoke about was that in the model that we had on the screen is that the patient is the larger wheel, and that it's the center and it's the driver for the rest. So if it stops, the rest stop moving. So that was a concept that we liked.
Bringing in all the different perspectives is definitely very important, and making sure the family understands how many stakeholders are involved in making it their plan rather than our plan. We have a group from SickKids here at the table that have gone through lean training, and they find that the process improvement practices brings in the entire team and all the stakeholders involved.
And we also had that it's what patients expect. So they expect that everyone's going to work together and be sharing information, and that it's going to be seamless. And so this is really aligned with, how they want the system to be and expect that it's going to be.
So the other additional points that we mentioned were that the process of collaborative practice eliminates hierarchy, is empowering, and also is a humanizing approach for all of us as professionals and also for patient and family.
One of our positive experiences is interdisciplinary documentation, just that it allows everyone to read the notes and kind of know in terms of what other staff are doing in terms of their treatment, and just trying to keep everyone on the same page. So that was one of the benefits of ICPM, that all of us could write together.
Having all staff at a huddle to discuss the patient and the patient's care, including the patient and the family, and including other services as well as, for example, environmental services, who can all have some input into the care of the patient. And the other one is empowering, and this was already mentioned, but empowering all staff to acknowledge and meet the needs of the patients. So just because it's not in your domain, not in their scope of practice, doesn't mean it can't be addressed. So if you're walking by a room and you hear a call bell, you go in, you acknowledge it, and you find the person that can do something about it. And I've heard that this is being practiced as well.
Hi. I know most people here are probably from hospitals, but I'll mention again that in home care there's challenges. The communication is a huge challenge because all the different providers have their own documentation and their own charts. So they either take it with them when they leave after the visit, or it's just for them. And there's also other restrictions in terms of like the personal support worker can only report things to their supervisor, who would then report to the case manager. They can't speak directly to other members of the care team. They can't talk to the nurse unless they happen to bump into each other in the home. They can't communicate directly with the PT or the OT. So there's a lot of structural limitations on communication, and a lot of that may have to do with the personal support workers being unregulated. And so, we had talked in other sessions about, not really understanding their role or their scope. So that's a huge thing, and also different providers, different organizations, you might have a nurse from one organization, a PT from another organization, a PSW from a third, so there's not that sharing of information or a common document that everyone can look to, so that's a huge barrier.
Real challenge, yeah.
So we spoke about that oftentimes you encounter individuals within a team that, or a group of people who don't feel that collaborative practice applies to them. And we talked about the need for organizations to have formal processes around addressing this. So there was a question of, what do you do when people say, I'm just not going to collaborate? And what's the recourse? And also, there's still a tendency we find to fall back on the medical model. So, it's great that we collaborate, but at times it ends up being, ultimately the physician makes the decision in certain cases.
We have several examples here, but I'll just pick out the highlights. We have a group from sick kids here that are already on the way to collaborative care, and they find that coordinating the activities, rounds, and getting the group together is often a challenge. The family's not always available, and it's time to. Can you hear me now?
Better.
That's better. Getting the group together is often a challenge. Getting all the people needed for a meeting or for rounds is a challenge. We also have Grant from British Columbia, who's just starting the journey and is finding that the concept is hard to get across to the staff and for them to see the benefit. As Cynthia mentioned, the branding and the way you convey the message to the people can be a bit of a challenge.
So one of the ones that we didn't think was touched on yet with anyone else is, due to all of the financial changes that are happening, sometimes this can lead to what we call turf wars, as individual professions try to sort of prove their worth and make sure that they aren't seen as a part of the team that can be eliminated. And so that might be one of the challenges going forward.
So we had two examples at our table. One was a way for doctors to collaborate with pharmacy, where patients are wearing wristbands with barcode, and every time a doctor wants to prescribe a medication, they're scanning the wristband, which goes directly to pharmacy. And every time the patient is then given meds, that's also scanned. So that's how they're working together. And then we had another example about the ED in the lab. The ED was looking at their wait times and reducing wait times, and the lab then looked at their processes to see how they could speed up their turnaround time and move people through a little bit quicker.
Where is that happening? At the same place?
That was happening at Kingston, was the ED, and the first example was North York General.
Thank you.
I'm actually working in the Education Services Department of KMH, and a lot of the research that we're doing right now is on including the family voice and including different perspectives in training of medical professionals, and to make sure that they're equipped to actually work with people that come from different perspectives. And I think that so far it's working quite well, and that's become a priority within the department. So I think that's sort of a good way to establish collaborative practice and just inviting those different perspectives into the discourse and the discussion. I think there was another example.
Yeah, I'm Alicia from Cancer Care Ontario, and one of the things that's going on there is some of our committees now actually are formed with people from different disciplines. So for example, we'll have social workers and psychiatrists and physicians and researchers, as well as patients and family members, all on a committee to help with provincial planning of some of our programs. So that's just an example.
So we had an example from CHIO that in the ICU they do team rounds. And what was very interesting about this is that they ensure that all members of the team are there. And so she gave the example that if, say, physio is working with a patient and physio is involved in the next patient they were going to discuss, they'll make a point to ensure that that person's a part of that discussion for their team rounds. and that they have a checklist to ensure that all members get to speak, which I thought was a really nice piece, because one of our challenges at board rounds is, it's led by people, by one person, or often it's the physicians that lead that discussion sometimes, but not everyone gets an opportunity because we're trying to get through things really quickly. So I just thought that was nice that there's an actual checklist to say, boom, 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 each person gets an opportunity to share.
That's great. So thanks, everybody, for your participation this afternoon. It's been a very full day, and everybody's managed to stay on task.